Good day, everyone. Welcome to Ryan Plastic Surgery Clinic. We are immensely honored today to have a distinguished plastic surgeon all the way from Australia with us. Dr. Lei, thank you so much for taking your time to come here. Before we delve into our questions, would you mind introducing yourself a little bit to the audience and also tell us about your clinic in Australia?
Sure, absolutely. Well, I'm from the Gold Coast in Australia. The Gold Coast is, you might have heard of Surfers Paradise. It's a beautiful part of the world. It's largely got a beach culture. We live not too far from the beach. And I've been in practice a long time. And I trained initially as a general surgeon and then as a plastic surgeon. I'm an ex-president of ASAPS, the Australasian Society of Aesthetic Plastic Surgeons. This is my second time in career. I'm really excited to be here again. I'm looking forward to having a chat.
Yeah, I think this interview might help a lot of people who are considering breast augmentation and other breast-related surgeries. So, having been a plastic surgeon for a considerable time, you must have witnessed the evolution of breast implants firsthand. What trends have you observed recently in this domain?
Oh, certainly. So I think the trends fall into two categories. They're those of implant development and changes in technique. So the technique changes have been quite significant over the last 20 years, and there's been a slow evolution of implants. So I think certainly when I started in practice over 20 years ago, the incidence of capsular contracture or hardening around the implant was around 30%, and it was even higher before that. And that was a combination of technique and implant. Currently, as you'd be aware, that rate is well under 1%. And so then there's obviously been a lot of that's been due to actually technique changes and combined with an improvement in implant quality. So I think it's the two go hand in glove, and I think it's important to use good implants, but also have great technique.
Yeah, I also absolutely agree with your opinion. In your professional perspective, would you vouch for the safety of breast implants?
Oh, look, absolutely. If I didn't, I wouldn't use them. The fact is that over the years, breast implants are probably the most investigated medical device there is. And there's constant supervision and looking at any issues that may occur. Throughout the whole world now, there are breast implant registries looking at all of these things. And certainly in Australia, we have one of the biggest, which is great. And so I think, implants have gone from a situation where even before I started, we had thin-shelled implants with liquid-type gels, which would then, if they broke, would rupture and could potentially spill into the breast itself. So we just don't see that now. I think the implants are very safe.
I think the breast implants are evolving significantly these days, so it's getting more safer. Do you also practice fat grafting to the breast?
Oh, look, absolutely. I think anyone who does modern breast augmentation, breast reconstruction needs to have that as part of their armamentarium that they use. I don't see it as a great tool for primary volume.
Me either.
It's great for finesse rather than volume. So I'm more likely to do a composite thing, put an implant in and then feather the edges, get a better cleavage in the appropriate patients. Very patients who need it often don't have enough fat to get there. It often requires multiple operations, and there can be significant secondary defects with irregularities and things, and it actually ends up being more expensive.
I think so too.
So the answer is yes, but in certain situations, and obviously in the reconstructive space, it's a really important tool. Every time I operate on a breast reconstructive patient, I add some fat every time.
So I think it's making better shape of the curve, but for projection, the fat can't follow the implants.
No, it can't do that. And as you know, you only get, say, half of it to take. So there are also issues with that, fat cysts and other things. So I think its role really is as an adjuvant to having an implant.
Well, this is an extra question. Well, 10 years ago, there was a kind of issue. A lot of doctors were using stem cell mixed with these fat cells. But do you think it's effective? For me,
I don't know if it's effective. I mean, certainly the science that I saw was the number of stem cells and things that you would require in order to make it work. You would need an enormous amount of tissue fat to get the stem cells to then put into some more fat, and it became not practical. Then on top of that, there becomes the argument as to is this genetic engineering in some way, and in certain places that would then be considered illegal. So there was a lot of discussion about that.
I always doubt about stem cells these days. We observe that over time the position or shape of smooth type breast implants might alter with the rise of women partaking in activities like Pilates or yoga, which involve significant muscle engagement. How do you tailor this surgical approach?
Okay, well, I mean, this is not a new consideration. I mean, back 23 years ago, I was doing endoscopic axillary round smooth mega pocket implants, and they all tended to move down and out with time. The big thing is this, is that the first thing from a surgical perspective is to create a tight pocket. So we learnt this with some of the older implants that we're using, particularly, for example, the 410 implant, which is a textured shaped implant. We really needed to keep a tight pocket to stop that moving around. So what I've found is that the transfer of that technique across to, for example, the Motiva implants or other smooth implants really means that you don't have too many issues with that. I obviously live in a place where there is, every woman's fit. And so what I say to them is that I want them post-operatively to take it easy when it comes to isolated chest exercise, particularly moving forward in the long run if they can. And certainly they can modify their behaviors. So, for example, if you're in a class where everyone wants to do push-ups, just do closed hand push-ups. It works the triceps, gives a beautiful shape to the arms. You can still be part of the class, but you're not trying to work the chest. I've already made you a beautiful breast. You don't need to go working on your chest. So that's certainly, I think they're the two main things that I do.
Okay. These days, I typically refrain from using drains, but here in Korea, some advocate is used to a ward-off capsule contracture. What's your stance on this? And could you share your outcomes based on your vast experience?
Well, I think you're right and they're wrong.
Oh, okay. Thank you.
So basically, it's not just on experience. The data shows us that. If you look at the 14-point plan, which is kind of almost the Bible of what you need to think about for primary breast augmentation nowadays, one of them is avoid the use of drains. Now, as an ex-general surgeon, I was always taught that you will never regret putting a drain in. Well, that's not true.
Oh, okay.
And about 15 years ago, I changed to not using drains, and it was one of those sentinel moments. It really changed the way I did things. If you think about it, we're creating a pocket that fits the implant perfectly. So I don't see any use for it, really.
Okay. What if the patient have a bleeding tendency, or she has a lot of disease related with hemostasis?
Well, once again, of course, you need to, in those patients, you need to try to optimize them preoperatively. And if that is too much of a problem, I wouldn't operate on them to start with.
Oh, okay.
So, however, if during the operation that we think there's a little bit more bleeding, there's a few things we would do. We might use some tranexamic acid, which will improve that. And, I may consider a drain. I mean, we don't need to be, you will never use a drain. In fact, I almost exclusively do IMF now, and so obviously I mustn't have any skill. but anyway, the fact is